Well, welcome everyone to It Takes a Valley virtual town hall. Today we're going to focus on our crisis response and transition services. My name is Mary Randall, and I am the chair of the Vail Health Foundation, and I'm co-chair of the Eagle Valley Behavioral Health Campaign Committee. I'm going to serve as the moderator for today's program, and I want to thank all of you for your interest and support in this important topic. Today, I'd like to start by introducing our panelists. And panelists, just raise your hand and say hi when, because you're all on mute, and then we will get you off of mute as it's time for you to speak. But we'll start with Carrie Benway, who's the program director for the Hope Center of Eagle River Valley. Welcome, Carrie. We're glad you're here. Chris Montera, who is the assistant CEO of Eagle County Paramedics. Hopefully you all won't have to see him too often, but every now and then, you never know. Glad to have someone like Chris in that role. And we have a new addition, Chief Dwight Henninger, who's the Vail Police Chief. He's been chief since 2002, and he's a new addition to our group, so thank you, Dwight, for joining us. Casey Wolfington is with us. She is the Community Behavioral Health Director for EVBH. We're so glad she's here. And we have a couple of folks who are in Vail Health related to the emergency services, and we hope they can join us, Nieves and Sarah Drew. So today we're going to have each one of these panelists talk with you, and we'll have questions and answers at the end of their presentations. Feel free to add any questions that you have at the Q&A widget that's at the bottom of your screen. Please note that's not the chat function. Feel free to add any questions and we will take those at the end. Before I introduce Chris and Dwight, I just want to say that what's impressed me the most about all of these people, oh great, we have Allie and Sarah here. Welcome, thank you for joining us. What's impressed me the most about this group is how everyone has come together to put together what's really an integrated and seamless approach to the behavioral health crisis response in our community. And I think it is something that many, many communities across the country could learn from. And hopefully you all will learn today more than you knew before you came in about how this works. So I'm going to turn it over to our first responders, Chris Montera and Dwight Henninger.
Hi, everybody. Thank you very much. And thanks for letting us join you today and talk to you a bit about what we're doing in the Eagle Valley around behavioral health. I think it's important as we start to talk about behavioral health in the county to discuss what happened and where we were before we took some of the great steps that we've done over the years. When we started a few years ago in 2018, we really had a disparate system. Paramedics and law enforcement officers aren't really equipped to deal with mental health crisis, although we go through a lot of training. It's really not the same training as a crisis clinician or somebody else like that in the field that they can really give the people in crisis. The other thing we also noticed too back then is we had the local resources just weren't there. We didn't have a lot of great resources, and inevitably we would have to take patients from the scene into the emergency room, really, which is really not the place for patients that are having a crisis or are in some sort of crisis at that time. So, and then the emergency room isn't really equipped to deal with patients in these crises. So we would then have to put them back in an ambulance and transport them hundreds of miles away to other hospitals, either on the Front Range or in Grand Junction. Sometimes we'd go as far away as Pueblo or Colorado Springs to get the patients the help they needed. And really, it wasn't really the greatest way that we could take care of patients. And we really view that mental health is a part of a whole health issue. It really has everything to do with the healthcare around every person. And from our perspective, it was really just not perfect. And I think what we've done locally has changed that. And Dwight's going to speak a little bit about the law enforcement side of the world.
Thanks, Chris. Yeah, when we started dealing with the mental health and sobriety issues with the folks out in the streets who present in crisis, we kind of had two choices. Either take them to the jail or take them to the ER. Neither is probably the best, as Chris just described about the ER, and somebody who's in a mental health crisis being in a jail cell, that's not really appropriate either. But that was our options, and the mental health providers at that time, I would only evaluate someone when they were sober. So if they were in crisis, we had to wait till they sobered up. And a lot of times if they sobered up and were happy and healthy, then we would just let them out the door with really no services. We might give them a pamphlet to encourage them to seek treatment or seek help with AA or something like that, but really not giving them services, and clearly not the world-class services that we try to provide here in the town of Vail and around Eagle County. If a suicidal party was evaluated by the mental health organization, a lot of times because there's very few beds around the state, they would be put on a safety plan. I'm aware of two circumstances where individuals put on safety plans and eventually end up killing themselves, which is terrible. It's hard on families, hard on the officers, really a difficult set of circumstances. And if we did find a bed for them, usually that meant an officer being away from the streets, driving them to Grand Junction, 2.5 hour drive, and then back, or going down to Pueblo, which would be a whole shift taking someone in for that. So not particularly good. And when we did do detox, we had a facility for them, but it was really just our bike storage facility, and we were doing that till the state shut us down there. So from my perspective, we really did not have a good set of services, and that leads to, we've been hearing a lot about police use of force and police, hurting people. And what the Washington Post data, which is the best use of force data, unfortunately, it shows that 29% of the people who have a use of force incident where they're killed in an interaction with the police have diagnosed mental health issues. So clearly a significant problem around this country. And you hear about the term defund the police. To me, that's more about shifting resources from policing to mental health, like we've already done in this county. Thanks.
Okay, that's great. Thank you. Now I'm going to turn it over to our representatives from Vail Health, from the emergency department, Nieves and Sarah Drew. Take it away, ladies.
Hi, thank you guys so much for having us. I hope you can hear us okay with our masks on. Sorry about that inconvenience. So we're going to speak just a little bit about what we're seeing in the emergency department currently around behavioral health. One of the most significant areas that we continue to see an increase in our emergency department patients is around substance abuse. So we're seeing an increase in patients coming in intoxicated on a variety of substances. Alcohol is the primary substance that we are seeing in the emergency department, but we also see patients presenting with issues around marijuana, both smoking marijuana and synthetic or edible marijuana. We're also seeing patients with methamphetamine issues and heroin. We see a wide range of patients in behavioral or mental health crisis as well. This continues to be an issue for us, and most of the time once patients get to our emergency department in this type of crisis, they are needing mental health evaluation and either transferred to an outside facility, such as one that Chris Montera already kind of touched on outside of the county, sometimes in Denver or Grand Junction, and often or sometimes in Colorado Springs as well. So we are able to stabilize some patients with outpatient plans, and we're seeing that be more effective with our co-response model and the support that we're getting from the Hope Center and Colorado Mountain Medical in terms of local outpatient resources. So that's been a great impact for us from the emergency department perspective.
And I just wanted to say, at Vail Health, we're very proud of the care that we provide to all patients who come to our emergency department. But just as Chris Montera mentioned, any emergency department in the United States is really not where you want someone who's having a behavioral health emergency. I'm sure you guys have probably been to an emergency department or urgent care at some point in your life. And nobody really wants to be there. Of course, we love it. It's our home. But you don't ever want to have to come as a patient. And so we're very proud, like I said, of the care that we provide and that we keep patients safe. But for to really solve people's short-term issues and to try to help them out with some of their long-term issues, they do require transfer a lot of the time. And so that's why it's so important that we do have an entire system that is able to wrap around the patients, because any one of our entities alone is not going to be able to tackle this.
Mm-hmm. And some of the wraparound services that we're seeing help our patients are things like crisis phone calls after an emergency department visit, direct contact with a patient to set them up with outpatient follow-up. So connecting them with a therapist or a case manager, which is something that we're seeing be created through these systems that we've been talking about.
Okay, thank you. Now I'm going to turn it over to Carrie Benway, who's going to tell us about the Hope Center and what it is and what it does. Carrie?
Thank you, Mary, and thank you, everyone. The Eagle Hope Center is a mental health agency that provides support to our community with two different programs. We have a school-based program that we'll talk about on a future town hall, but today we're talking about our mobile crisis co-response team. And that team responds to calls to our 24/7 Hope line, and it also provides support after hours and on weekends to Vail Health and to the Eagle County Jail. And I want to mention, this is very important, all of the services that the Eagle Hope Center provides are at no cost to the individual. And that's thanks to you, our community members who support Vail Health and Eagle Valley Behavioral Health, and to our significant community partners who are on this call. Partnership is really important to our mobile crisis co-response team. We start with law enforcement. Without law enforcement on scene with our licensed therapist, our therapists would not be safe and our community members would not be safe. So thank you, Chief Henninger, for this partnership. And then we have Chris Montera and his team. They also respond to us on our calls, with our community paramedics. And these community paramedics add depth and comprehensive care by being able to attend to medical needs of an individual who's in a mental health crisis. So you have the Hope Center licensed therapist who's able to perform a behavioral health evaluation on scene. And then we have the community paramedics and law enforcement. So thank you. And you might wonder what happens when somebody calls the Hope line, which is 306 HOPE, easy to remember. And what happens is we receive the call and our intake coordinator connects this individual who's calling with a licensed therapist. Then we respond to wherever that individual is calling from. That could be a park, it can be a community member's home. Since I've started in January, I think we've responded 3 times to a gas station. But the beauty of the program is that there truly are no barriers to access. Simply by picking up the phone, a community member is connected with a licensed therapist at any time of day or night, 365 days a year. And again, that's not possible without our partnerships. So thank you. And I'm really looking forward to questions because I could talk about the Hope Center all day. But when I think about what we've accomplished since we opened in October of 2018, for the first time in 2019, we were awarded the state crisis contract from Rocky Mountain Health Plans. And with the Vail Police Department, we submitted a successful grant application to the Office of Behavioral Health. These were 2 significant successes in 2019. Again, all thanks to partnerships. And most importantly, we are providing opportunities for individuals in our community in an emotional crisis to stay at home with their family, with their network, and we provide the wraparound services to make sure that they're safe. Our clinicians are able to evaluate the person and come up with a safety plan. That might involve check-in calls for 2 weeks or a week. And what happens with the check-in calls is we make an agreement that the individual is going to call at a certain time of day. And if we don't hear from them within that minute, we are calling them. And then if we are not able to get in touch with that person, we reach out to law enforcement to do a well check. And the other, I have to speak about Colorado Mountain Medical's behavioral health team. It's been an amazing resource. Believe it or not, they hold crisis spots for us on a daily basis, 2 spots a day. And they also implemented an IOP, an intensive outpatient program, which we are able to refer people to. And their scheduler responds to us within minutes. It's unbelievable. We have, the response is amazing. And then we are able to utilize Olivia's fund, which is just such a gift to our community. And thank you to all of you who support Olivia's fund. It was 2 Saturdays ago, I received a call from a crisis clinician, one of our crisis clinicians, and he said, Carrie, I really need somebody to get this spot on Monday. They need the crisis spot. I said, no problem. I reached out to CML, we lined it up. And then on Monday morning, my intake coordinator said, well, this person can't pay for it. Then I reached out to EVBH and they're like, no problem. We can get the funding from Olivia's fund. So when I say there are no barriers to access, it's true, because we have the funding and we have the agencies providing the support, and it's not us working alone. It's us working as a team. And I really thank EVBH as the organizer of all of us. And during COVID, especially, feeling included and connected with all of our resources has been such a gift.
Great, thank you. Thank you, Carrie. Now we're going to turn it back to Chris and Dwight to talk a little bit about how things have improved with the Hope Center and our 24/7 crisis response.
Well, Carrie, we can't say enough nice things about what you guys do in the community. And it really, I think the proof is in the pudding. When we started looking at a model to emulate, there are other models around the country in pockets where they pair a paramedic and a crisis clinician, or a law enforcement officer and a crisis clinician. And I think in our community, we've really solved that by pairing all three of those together. One of the great models that we've seen too, and sending the community paramedic out, it helps the crisis clinician know that they have another resource there. Oftentimes when somebody's in crisis, we find that they have a social determinants of health issue. So what does that mean? It means that maybe they can't make rent, or maybe they're going through a divorce or something like that, that maybe it's not a typical what we would call mental health issue where they have a diagnosed mental health issue, but they really do have some other outside pressure on them. And this is it's kind of like the straw that broke the camel's back. And we're really trying to figure out how we can bring all the resources together to patients that really need us. One of the great successes of this program was really early on. In fact, one of our very first patients in the program, we were called out with the Hope Center and one of our community paramedics, and the woman wanted to hurt herself, and she said, I can't make rent. I can't make rent next month, and what can I do? And so because of that, the community paramedics came in and did some follow-up and got that person connected with human services to get their rent covered for the next month, and then got them into the food pantry to get their food needs taken care of for the next month. So really, it's that community effort, bringing everybody together. And I think that's where the success of this program is. And because of those efforts, we have reduced the off-scene ambulance transport for these patients by 74%. So all patients, all comers. So these are patients that we are able to keep at home, keep in their environment, and not move them to the emergency room and then to the front range, where they're going to rack up somewhere in the neighborhood of between $20,000 and $40,000 of healthcare bills that they weren't expecting. So now we're adding more insult to injury when we can take care of their problem locally. And I think that's been one of the great partnerships with it that we've seen. And really, it keeps those costs down, and it's very cost effective to be able to utilize CMM and all these providers in our community. And I think that's where the Hope Center has been great. They've been able to come out, do the crisis call, and then refer those patients locally to other clinicians that can help patients long term. I think another thing that is kind of top of mind for a lot of people right now, and I think it's in the headlines, is the use of ketamine. And I think it's important that we bring it up quickly, because ketamine is something we do as paramedics. It's not something law enforcement officers do. But until we started giving ketamine about 3 or 4 years ago, we saw a lot of patients, not only in our community, but nationally, that were dying from something called agitated delirium. And what it is basically a person gets so agitated that their body basically shuts down and they die. And now with the use of ketamine, we've really seen great results with that. And patients are walking out of the ER where before they weren't, and they were dying on scene, or we would see very, very poor outcomes. So when people start talking about ketamine, know that it's a great resource, and it's nothing that law enforcement does. It's not something they do. It's very much in the hands of the paramedic when they get there, and they're the ones that are actually administering it, monitoring that patient, and taking them safely to the emergency room. So as you hear things in the media, know that those things are very safe that we do. And it's something that we've used as a tool, and we rarely use it in our community because we have the crisis clinicians, and we have the ability to de-escalate scenes and patients very, very much a lot of the time. And in fact, our ketamine use in our community is very, very low. But I think it's important to talk about that as we talk about all the things we're trying to do in our community that make it safer for our patients that are in mental health crisis.
Thanks, Chris. Yes, Carrie did a really good job of explaining the co-responder model. And, you know, if you take what we used to do where a young police officer would put somebody in jail or take them to the emergency room, if they went to the jail, we would let them out when they were sobered up with maybe a pamphlet. We've come so far. It's so exciting for me. And as Mary said, this is a model for other places around the country. Just to be clear, so somebody calls 911 and an officer will go out if it's unclear what the crisis is. If they need help, they will call the community paramedic and the Hope Center folks. If the dispatcher, when the 911 call comes in, is pretty clear, they will send all three of those resources as appropriate. So we're getting there quickly. We're helping the person find the best appropriate resources to deal with their problem. The officer makes sure the scene is safe, and when the Hope Center and the community paramedics say it's safe, the officer can leave and go on to other things. So a call that might have taken us a couple hours now maybe takes us a half an hour to 45 minutes, freeing up those valuable law enforcement resources. The quality of care from Dwight's perspective is so much better occurring in the home. And as Chris said, a pretty significant reduction in how many people are going to the ER. And there's a 64% reduction in the amount of people who are being transported to Grand Junction or Pueblo for a mental health hold, which is a huge problem in itself, that they've been transferred way away from any resources that they do have to one of these facilities that are locked down and are really problematic. So that's another huge statistic that's really shows the value of this program in the short time it's been in place. From my perspective, the COVID-19 coronavirus has more psychological issues and behavioral health issues than it does physical medical issues. And so if we hadn't had this system in place when this virus attacked our community, we would be even more troubles than we do have now. And what I'm seeing is a lot of the calls that used to go to 911 are now going to the Hope Center or one of the other crisis lines or the other resources that are now in place that were not in place 18 months ago. So that's pretty exciting to me that we put that in place before we knew COVID would hit. And we're in a really good place now, having all these resources to deal with the issues that are coming up, and we would be in a world hurt if we didn't have those. The other thing is right now we have a contract and we're able to take folks who are under the influence of alcohol and drugs to a detox center over in Summit County. And we're excited about the fact that Eagle Valley Behavioral Health is working hard to build a facility here. And we're excited about that opportunity where we can take people who are really in need of those crisis care responses and not take them to our bicycle storage room where we used to take them for detox. So with that, Mary, we'll turn it back to you.
Great, thank you. And next, I'm going to turn it back to Allie and Sarah to tell us more about the positive changes in the ER that they've seen.
Yeah, thank you. So I think one of the most positive changes we'd like to speak to is sort of in line with what Carrie had mentioned in regards to the partnerships that have been formed. So when we are navigating care for patients who are in mental health crisis, which just to kind of describe what that means to you guys, mental health crisis is someone who is generally feeling suicidal. or someone who is potentially feeling homicidal, or someone who's experiencing symptoms that are causing them to be gravely disabled due to their mental illness. So uncontrolled psychosis or other presentation of instability due to their untreated mental illness. So when we're navigating the course of care, one of the really positive impacts we've seen from these new partnerships is this ability to create these warm handoffs for patients to access the care that they need locally whenever possible. So Carrie spoke to Olivia's fund with eliminating barriers to accessing care. Financially, it is a huge barrier to accessing therapy or treatment for something that can sometimes be considered a luxury treatment to be able to have. So usually when people are suffering and struggling, considering putting $100 a week towards mental health therapy is not something that they're willing to do. So they continue self-medicating with alcohol or using other unhealthy coping strategies instead of accessing that care that could really help them through the crisis they're in. So being able to access Olivia's fund and connect patients immediately to behavioral health services, CMM has been a huge resource for us in just really expanding the timely access to treatment appointments. So historically, we've seen a real delay in how quickly people can get in to see a therapist when they want to, or even see a psychiatric provider to medically stabilize them without having to send them to a hospital in another county. So those partnerships have really been one of the biggest takeaways that we've seen. When the Hope Center is in full force, we definitely have seen a reduction in our patients who come to the emergency department and are able to safety plan into the community. And that's really showing that the patients that do come to the ED need to be hospitalized. There isn't a safe way to keep them in the community, and they need that higher level of care. So that's it demonstrates an effective usage of that community-based system and preventing them from getting to the emergency department in the first place. Is there anything else that you can think of, Sarah?
The only thing I was just going to mention was just, throughout the years, we've had different iterations of programs, that we've tried to put in place to wrap around this population of patients. But in the last year, we have had really solid collaboration and a lot of, at minimum, monthly meetings with, not only people from the Vail Health side, such as Allie running a lot of the meetings from social services and representation from the emergency department, but Eagle Valley Behavioral, the community paramedics with the Eagle County Paramedics, the Hope Center, Mine Springs, CMM, and different folks like that. We are meeting at minimum, like I said, on a monthly basis to talk about our systems. And that is one of the biggest improvements that I've seen is not only are all of our relationships much stronger, but we're working on it as an entire system so that we can try to help this patient population from every angle that we possibly can.
Great, thank you. And now I'm going to turn it over to Casey Wolfington, and she's going to tell us more about Eagle Valley Behavioral Health.
Absolutely. Thank you so much, Mary. And as you guys heard, for a large part of its history, Eagle County was a behavioral health shortage area. And so Eagle Valley Behavioral Health was designed and created to lead concrete community collaboration to transform Eagle County's behavioral health system. So when we're talking about behavioral health shortage areas, we're talking about both in terms of providers as well as services. As you guys have heard, again, I'm repeating a lot of this, but when somebody needs higher levels of care, they're often transported out of our community. And really the only option within our community for the vast majority of our history was inconsistent outpatient care. And I say inconsistent because it was incredibly expensive. Very few, less than 9% of our providers before Eagle Valley Behavioral Health was formed, accepted private insurance or public options such as Medicaid, Medicare. And the wait list of these providers were so substantial that it just created such a large barrier for so many individuals. Oftentimes, when people had the ability to private pay, they would be on the road and driving to Denver to access that level of care. And that the providers also felt very overwhelmed in our community because the type of services provided were only outpatient, which means that a lot of our providers were reluctant to see higher needs patients because they didn't have the support that they would have in a traditional city or even urban, suburban area. And so oftentimes the people who needed to access the care the most in our community were unable to. And then again, when we're getting access to care external from our community, that means that when people come back here, they're completely unsupported. So one of our most successful programs in enhancing behavioral health access, affordability, and quick and easy access to care has been the integration of Colorado Mountain Medical in their integrated behavioral health team. As you guys know, Colorado Mountain Medical serves 90 to 95% of our population. For kiddos that are age 5, that means that at age 5, one kiddo has probably been in that clinic up to 10 to 15 times. And so that means that our community has extreme trust, familiarity, and are very connected with those doctors. So being able to infuse behavioral health in that community clinic has been incredible for stigma reduction, as well as just this integration of this whole health model where we're addressing physical health and mental health all in the same place. As you have heard people say before, one of the things that is the most important at Colorado Mountain Medical and with Eagle Valley Behavioral Health is to be completely community responsive. So we have those 2 crisis slots that are held every day, which means that if anything comes up and it's urgent for our community, people are able to immediately access care. We are constantly assessing the caseloads of those providers because we want to be ahead of the need. We never want anyone to have a wait list or have a barrier to seeking that help. So we're constantly identifying when those providers are going to be full. As Ali mentioned, we also created right in the middle of COVID-19 an intensive outpatient program, which I always like to say sort of branches both sides of a mountain. So people who have symptoms that are escalating, we like to have this type of program in place so we can prevent hospitalization. We can manage these escalation of skills here in the community. It's a 3 times a week, 3 hours a day. It's a very intensive clinical program. Or those that have been at a higher level of care, such as inpatient, then we can help step them down successfully. Prior to this intensive outpatient program, we had very few programs in our community that were operating at this level of intensity. And so that step out of intensive inpatient care was very difficult. And we have a lot of collaborations with pretty much everybody on this panel to make that successful. One of the other really unique things that Eagle Valley Behavioral Health, with the generosity of Vail Health and the Vail Health Board, have been able to implement is this concept of community behavioral health navigators. Probably the vast majority of people who are on this call know what their healthcare covers with regard to physical therapy. You probably know if you have 10, 15 visits for physical therapy, but the world of behavioral health and insurance is completely different. It is very difficult to access your insurance benefits. You may be in network for your medical coverage and out of network with behavioral health. And as you guys have heard Chris Montera talk about, there are so many other components that contribute to behavioral health when we're talking about social determinants of health. That although traditional counseling may be incredibly important, food may be equally, if not more important, housing, shelter. All of those components are so important. And prior to this, traditional behavioral health providers were trying to manage their caseload and also trying to support their clients with this advocacy and case management. And so what the behavioral health navigators do is really take on that coordination case management role. We try to demystify all of the different systems where people can access resources. Oftentimes, if someone is anxious or depressed, making a phone call is not in the realm of possibility. So having someone walk them through this, while we're also preserving the clinician time so they can actively engage with the people who need it most. And I think that's one of the most important things. And then one of the last things I'll say, because, you know, a lot of individuals have brought up this idea of collaboration and how important that is. That's one of the main pieces that Eagle Valley Behavioral Health looks at. A lot of the organizations that have been providing behavioral health services in our community were entirely grant funded and very grant driven with regard to their service delivery model. Eagle County is very unique in that there's a fire truck going by, that we're very unique that we have a large population, but not large enough to qualify for some of this federal funding. But through the coordination of Eagle Valley Behavioral Health, we have really been able to bring a lot of organizations together to really make the numbers work. You heard Dwight talk a little bit about a detox center that we're helping support in Summit County. We're really looking at our mountain region where people live and work in cross counties, but really also looking at our home-based nonprofits and trying to create collaborative partnerships so we can successfully obtain grants. You know, we recently obtained one from HRSA, and we constantly work with the CATS Amsterdam Foundation and really trying to demonstrate our need for behavioral health services in a way that individual entities cannot, but a coordinated entity can.
Great, thank you so much, Casey. Now we're going to turn this over to the question and answer portion of our program. Again, please feel free to add questions where it says Q&A on your screen. Feel free to direct the question or whatever. And we did receive some questions ahead of time, and those are the ones I'm going to start with, and then we'll go to the ones that came up during the session. So the first question is for Chris. And this question says, please outline the crisis response path from the 911 call to long-term treatment. Who are the partners and how do they coordinate?
Well, we're all here. So the call can come in several ways. It can come in via 911. Sorry, let me turn down my radio. They're out working right now. So the call can come in several ways. It can go into the crisis line. It could come in from a responder in the field. It could be a law enforcement officer or a firefighter or a paramedic in the field. It could also just come in from a concerned citizen on 911. So it comes into a coordinated center. Then the appropriate people are dispatched. Generally, law enforcement goes, as Dwight kind of outlined earlier, just to make sure the scene is safe and to make sure that the crisis clinician and the community paramedic are going to be safe when they enter the person's home or their vehicle or whatever it may be, and that there aren't any acute issues that may harm those responders. Once everything's determined safe and the community paramedic and the crisis clinician feel it's safe, they will release that law enforcement officer. And then the real work begins. The crisis clinician starts to dive in, and Carrie can talk about this. This is completely out of my forte, but she can definitely do that. But she could talk about what types of intensive treatment they do right there on scene. Our community paramedics are there to assess the physical health of the patient, to find out if they are on any medications that they need to take routinely, go through their, do what we call a medication inventory and make sure that they have all their medications they need to be on. Go through our social determinants of health, make sure that they have food and water and shelter and all of the important pieces. And then if the patient's healthy, safe, and has all of those needs met, our community paramedics may or may not stay with the crisis clinician, and then the real work begins, where the crisis clinician then does that deep dive with those patients. And then Carrie, do you want to talk about what happens once the crisis clinician takes over and then into a little bit longer term treatment?
Certainly. So with our crisis clinician on scene, they provide the behavioral health evaluation. This person may be somebody our team has seen before, and they are able to assess the individual's safety, whether they're safe to be to do a safety plan that just involves the Hope Center, Or do they need a safety plan that involves the IOP program at Colorado Mountain Medical? Does this person need to be transported to Vail Health with an M1 hold? Those are the things that we are fortunate to work with Allie and Sarah and their team to be able to, when that is needed, we use the least restrictive means possible, but what is the most important is the individual safety. And if an M1 hold is needed, we work with Allie and Sarah and their team to provide a psychiatric hold. But typically what we do with our team is our crisis clinicians are assessing the individual, determining that they are okay to stay where they are, and doing safety plans that involved check-ins, coming into our Hope Center office here in Eagle, or connecting them with a community partner. And I think it's really important to note this warm handoff piece. It's not like we would say, oh yeah, here's the number for Colorado Mountain Medical, give them a call tomorrow. We make the phone call. We talk to Dale, their scheduler. We have those relationships. And the warm handoff to me is very, very important.
Great, thank you. The next question is for both Carrie and Casey. What adjustments are we making to help combat suicide among all age groups?
Casey, do you
Absolutely. I'll start, and then Carrie, I'll turn it over to you. I think one of the biggest pieces is enhancing access to care, normalizing care, and destigmatization. And so you see our different campaigns, and I think that has a huge component to it. But I think when we can increase access to care and normalize a community's ability to receive care, what we're doing is we're encouraging our community to start to seek care when things just start to bubble up. Across the board, I think it's so fabulous that we have the emergency department here, because I think they can really speak to this as well, that for so long across our whole United States, behavioral health care usually only gets utilized when there's a crisis. Even during question and answers like this, one of the most common questions I get is, how do I know when it's time for me to suggest to someone to seek services? How has it reached that threshold? And there's almost this concept that we have to be in this very horrific state of mind to utilize counseling services. And the fact is that the counseling services are the most effective when we can use them early and often. So I think increasing access, decreasing stigma, and then again, what we're doing with our youth. You're going to hear in a future town hall about the Hope Center being embedded with our schools. At Colorado Mountain Medical, the behavioral health team is part of all of those check-ins, those early well visits with the kiddos. And so our youth are starting to talk about behavioral health in the same way they talk about physical health. So we're creating a new landscape for them.
Well said, Casey. And I would just add that during COVID, specifically stay-at-home orders, we began hearing from community members who didn't even live here, who I remember a parent calling from Boston, very, very concerned about her son who was isolated at home and not sounding good. And, that hearing that parent voice saying, I think my son needs help, I'm not sure what to do. And by calling the Hope Center, the more people who know about the Hope Center when they look at resources at EVBH, by calling us, we are able to connect before the crisis. So I really appreciate you saying that, Casey, because I think that's important for people to know that anyone can call the Hope Center. You get just with a concern, not waiting until the crisis. And I'll look forward to the town hall on the school-based program, because I do have some wonderful success stories about kids walking down the hallway saying, hey, that's my Hope Center therapist, and therapists saying that kids are approaching them saying, you help my friend, I think, I want to see you too. And just decreasing that stigma. And as we branch out into elementary schools, it's gonna be amazing to see them grow up and with talking about their own mental health. It's a real gift from our community.
Hey, Mary, can I add on to that one
Absolutely.
quick thing?
Yeah.
I think it's important if your car was making a noise, you wouldn't wait till the wheels fell off to go get help. If your body is aching and your right knee is hurting, you're not going to wait until your knee falls off to go get help. And so I think when we talk, mental health has just been this taboo in our society for so many years that now we're saying it's okay. It's okay if you're like, I'm a little off, I just need to go get some help. That's okay. And so we're trying to relate it back to things we do every day. And it's really okay to get help anytime.
Great, thank you. The next question really relates to Olivia's fund. And can you describe a little more about what it is, how it works, and how many people are actually using it?
Absolutely. I'll take that one. So Olivia's fund is our no barrier access to behavioral health care. So it's open to our entire community. There is an application process that has certain guidelines that we had to put in place, but really we have tried to make it as barrier-free as possible. I actually have never seen an application come through that hasn't been approved, and that our community receives 6 behavioral health visits completely free of charge. And what we're really trying to do is take all the barriers out of accessing the care for Olivia's fund.
Great, thank you. This next one is, I'll start with Chris and Dwight. If you could look out 10 years from now, what success stories would you be celebrating? And what do you need to see today in order to create those successes?
Dwight, you want to go or you want me to go?
Go ahead, Chris.
Okay. I think it's simple, 0 suicides. I think that if we're going to start at an easy goal, at least an easily measurable goal, is to have 0 suicides. And success for me in 10 years also looks like the fact that we can have these open conversations about mental health. Like, hey, I went and saw my therapist yesterday, just like I said earlier, I just went and saw my doctor the other day because I had a blah, blah, blah. It should not be any different. And I think that's success in my mind.
And one thing I will add to that, oh, sorry, Dwight, go ahead.
Right,
Okay, that I completely agree, but it's not decreased utilization of behavioral health services, it's increased utilization. Just like we are hoping that people are getting their prevention checkups, they're getting their teeth cleaned, they're doing all of these preventative measures, I hope that the utilization of Olivia's fund is extremely high, and if it's not high, it's because we were successful in lobbying for insurance reform, and now insurance is actively covering behavioral health services in a way that our community can utilize.
Yeah, I would just add, I agree with Chris's no suicides goal. I also think a facility where people could get all levels of care would be super helpful, whether it's a walk-in for an adult or a juvenile, or somebody just needs a little bit of time to catch their breath in a respite center, or a detox facility where they're not sitting in our bicycle storage room with a police officer watching them with no services at all, or if they're in a full crisis mode. So having that facility would be super helpful for our community so that they don't have to be transported out of the community where they have no resources. So I think having the facility and 0 suicides would be my 2 goals, or my vision.
Great, thank you. The next question is, again, for Casey or Carrie, when there's an acute case, like someone needing a higher level of care that isn't available in Eagle County, what's the process to place them in another facility or service outside of the community?
And I would actually include Allie and Sarah in this because we rely on their team when we are placing an M1 hold. We work, that's Allie's expertise.
Sure, thanks, Carrie. So first of all, a mental health hold or an M1 hold is referring to an involuntary transfer to mental health treatment inpatient that can last up to 72 hours. Basically, it's giving the facility time to do a full and comprehensive psychiatric evaluation for a patient and create a safe discharge plan so that they have access to all the resources that they need when they discharge from the hospital to continue to be safe. So when we do get to a point where we cannot keep a person safe in our community and we initiate a mental health hold, and coordinate a transfer to a psychiatric hospital, there are a couple of factors that we look into. First, one of the factors is payment method. So we want to make sure that we're not creating an additional burden for that patient or their family, and we want them to get to a hospital that accepts their insurance, that will ensure that they're fully covered for that visit. And then at that point, we're also looking at availability and appropriate treatment. So what that is really looking like in our state right now, because we don't have any of these psychiatric hospitals available locally at this time, is that we're looking at facilities in the Denver area primarily, or at West Springs Hospital in Grand Junction. And one thing that has really shifted over the past couple of years is a more timely access to bed availability in these facilities. So we really aren't seeing the delays that we once saw, where we can't get patients into those beds for 1 to 2 days. We're really looking at a turnaround of 15 minutes to an hour to get bed placement and acceptance of these facilities. Which is fantastic, because like Sarah spoke to before, while we love the emergency department, it's not where our patients want to be and where they are getting the level of care that they need. It's really a holding place for them to be safe until we can get them to the right level of care. So it's great that we're looking at this quick turnaround. The other thing that's really shifted in some of the inpatient hospitals that we're working with is the specialization of the care that they're providing to patient populations. So we refer, one recent example that I've had is actually referring a provider on a mental health hold after a suicide attempt. And we were able to refer her to a hospital outside of Denver that had a HEROES unit. So it was a unit for first responders who were experiencing a mental health crisis and needed inpatient hospitalization. And so being able to connect that person to that unit was, you know, incredible for her treatment and her recovery from that incident. We also have access to specialty locations for people with severe trauma. So units that have only female patients and female providers for people who are severely traumatized or can't manage being in a mixed environment in terms of gender. So those are just two examples of the type of specialties that we're trying to look for when we're making these placements happen, so that even though it can be a very unpleasant experience to have to go to a psychiatric hospital because you're in crisis and it's probably the worst time in your life, we're at the very least trying to connect you with the best possible treatment location and the most specialized care that we can, so that you're getting set up for success in your recovery.
Great, thank you. I have another question for Allie and Sarah. When patients come to the emergency department with a behavioral health crisis, are they coming with their own? Are they coming on their, with their family? And are they being transported by an ambulance? How does that mechanics of that actually work?
So all of the above. We see patients who come in by themselves, sometimes seeking care. We see patients who come in with family or friends, and we certainly see patients who either come via ambulance with the community paramedics, or sometimes, honestly, people might be involved in a trauma and also be having a mental health crisis. So we see a wide variety we have over the years, and we also continue to see that. We also sometimes, honestly, will find people in the parking lot or in our lobby who have showed up here because hospitals are a place that you can seek help, and they might not even know exactly what they're looking for or how they can help. So when we find people in any of those situations, they're first met by a registered nurse, with emergency department training and all of our certifications, and they are triaged. And then depending on their current needs, medical, physical, and psychiatric, will determine where we end up placing them in our emergency department, and also how quickly we're engaging Allie and her team. Because if a patient, for instance, was like an overdose or had some type of trauma, we maintain their safety, but also will address, their medical and trauma concerns initially.
Great, thank you. This one's for Dwight. How can we as normal citizens support your great police departments?
Well, Ann, thanks for the question. We really appreciate it. I think all of the agencies here in Eagle County would really appreciate if each of you would just say thank you when you see officers in the community. That would go a long ways these days. I do have to say that Eagle Valley Behavioral Health's work has made it easier to be a police officer here and feel good about the work you're doing, because we don't have to worry about not having services to provide, and us providing the mental health counseling, and us making the decisions about whether somebody needs to be M1, as Ali was talking about. That is super helpful for us. In addition, we've been able to fund a number of courses through EDBH on crisis intervention team training and mental health first aid for our dispatchers and police officers, which helps us have a better understanding of how to deal with people in crisis, where before we were relying on maybe a 4-hour class in our initial police academy class. I do want to stress that the departments here in Eagle County all have good policies and procedures around use of force, and many of the issues you hear at the national narrative are already taken care of here. So that's why you're not seeing those things. And really the work we're doing around the co-responder model is a best practice, and we're super excited to be a part of that. We feel much better about the work we're doing. Thank you.
Great. The next question is for Carrie and Casey. Can you discuss how the Hispanic community is learning about the mental health access and the importance of it? And maybe others want to chime in, but we'll start with those two.
Absolutely. You know, I will mention that all of our publications with regard to Olivia's fund are both in English and Spanish. We're really working to get our messaging out to the Latinx community with organizations that they are already engaged in, that they already trust. So we work very closely with Hearts Reign. We work closely with Mira. We are working with the new Youth Center, which is such an incredible resource to make sure that our messaging is meeting the community where it's at, and we're not expecting the community to try to find that messaging within the Vail Health website or any pieces like that. We have also been very successful of word of mouth and collaboration with people who have utilized our services.
Carrie, you're on mute.
Excuse me. Just in this past month, I've received emails from other organizations, other providers asking specifically for this type of support for our Hispanic community. The Hope Line, we do receive, I would say, almost an equal call volume from individuals calling that are Hispanic. And then when I reflect on the 1920 school year, the total number of students we served, it's equal between half Anglo and half Hispanic. So we are definitely serving the kids in our schools. And again, it's that their parents know that they're seeing a Hope Center therapist at school. And then we make sure that everyone we serve knows about the Hope Center crisis line, because after school hours, any family that needs help can call the crisis line.
Great. Well, thank you all. We are unfortunately out of time. We will try to answer individual questions directly back to the person who asked the question in our follow-up. And I'm sure you all agree that there's a lot of impressive work being done here, and this is a model that can be replicated in other communities and in our state and in the nation. And I invite you to go to the website, ittakesavalley.org, to learn more about EVBH and our partner organizations, and hopefully make a donation. I have to put that little pitch in there, you know. I want to thank all the panelists and all the attendees for being here, and also invite you to go to eaglevalleybh.org to look at some of the key tools we have, which include a therapist finder, how to get help now, and more information on Olivia's fund. So thank you all. This session is also being recorded, and we will be sending it out to you and to others who were unable to participate. So thank you all again. We really appreciate it. Bye-bye.